Thank you, course.
All right, start. Start.
Okay, sir. Um, Good morning, teacher and dear friends. Today I am here to present on the topic maturity indicators. The contents for today are introduction, requirements, clinical importance, various ways of expressing age, and skeletal maturity indicators. Now, beginning with introduction, growth maturation occurs at different times in different individual due to individual variations in time, duration, and velocity of growth. Age assessment is essential in formulating orthodontic diagnosis and treatment plan. Now let's talk about requirements of maturity indicator. They should be safe, non-invasive, require minimum radiation, should be accurate, and stages of maturity indicators should be well defined and easily identifiable. It should be cost effective with minimum armamentarium and personal requirements. Method should be simple to conduct, should be valid over time and across age group, and also should be accepted worldwide. um, Now, moving on to clinical importance of maturity indicator, it is used to determine the potential vector of facial development, to determine the amount of significant craniofacial growth potential left, to evaluate the rate of growth, to decide the onset of treatment timing, to decide the type of treatment, to evaluate the treatment prognosis, and to understand the role of genetics and environment. Before moving on to the main topic for today, that is the maturity indicator, we need to know about age because the key to successful treatment is to start at the right age. And age can be expressed in number of ways like the neural age, mental age, physiological and biochemical age, chronological age, sexual and pubertal age, dental age, and age determination using growth charts. Finally, the skeletal, anatomical, and the radiological age. And the first is the neural age. It helps us to understand that the patient is mentally developed to understand the need for treatment and what extent will the patient be able to cooperate and follow the instructions properly. Gessel and his colleagues in America created a certain landmarks of development, and the development landmarks is divided into age with respect to months and age with respect to years. Now, talking about age in months, if a child follows moving object with eyes, then that denotes that the child has a neural age of 2 months. Likewise, a child of 4 months can sit propped up for a short time, moves head to inspect the surroundings, and child of 6 months can grasp objects, begins to bang and shake them. In 8 months of age, the child can sit unaided, and in 10 months, the child can creep, pick up small objects between fingers and thumbs, can speak 1 to 2 words, and also tries in helping with feeding. Now, moving on to age in years, during the first year, the child can cruise along holding onto the rail of a cot, walks with one hand held, throws objects on the floor, cooperates in dressing, waves goodbye, puts toys in and out of container, and in 1.5 years of age, the child can now run, walks awkwardly and stiffly, builds towers of 3 to 4 blocks, and can turn pages of a book and has a vocabulary of about 30 words. And in 2 years of age, the child can run without falling, uses 3 sentence words, can turn doorknobs and obey simple instructions, and can build tower of 6 to 7 blocks. And bowel and bladder control is sometimes good during this age. Um, Now, in 3 years of age, the child can walk erectly, stand on one foot, they can climb and can put on shoes and unbutton some buttons. The bowel and bladder control is usually established by this age, and the child can also eat reasonably well by himself, and the counting begins in this age. In 4 years of age, the child then now begins to draw, copies, and write alphabets, cleans teeth, washes and dries face and hands. And in 5 years of age, the child can tie shoelaces and begin to use tools. Some read quite well in this age, and most can write their own names. And questions about meanings of words also arises during this age. And finally, in 6 years of age, the child can read, play, and balls that are bounced are sometimes caught by them in this age. Now, next is the mental age. It helps in determining the outlook of the patient towards the treatment, and it also helps in assessing the expected level of cooperation that we can expect from a patient. And mental age is usually calculated with the help of the intelligence quotient, and there are various performance tests to measure the IQ. The IQ obtained can then be classified by Stanford Binet test or the Wessler scale. This is an example of the Stanford Binet test, where there are ranges of IQ and their corresponding classifications. Like if a child's IQ lies in the range of 120 to 129, then it is classified as superior. Similarly, if the IQ lies in the range of 80 to 89, then it is classified as low average. Besides this IQ, another method of estimating the mental development is to use the standard capacity of the child to read. Now, moving on to the psychological and biochemical age, a series of psychological and biological changes occur during growth and can be correlated to the skeletal and chronological age. A study related to the synchronization of adolescent blood pressure and pubertal somatic growth was done, and it was found that the average pubertal growth spurt for girls was 11.5 years and 13.3 in boys. In the same year, the mean systolic BP was 100 mm of Hg for girls and 107 mm of Hg for boys, and the mean diastolic BP was 59 mm of Hg and 61 mm of Hg in boys. In this same study, the rate of change in this systolic BP and weight was found to be peaked precisely at the estimated pubertal growth spurt. Um, uh, Besides this, there is also a fall in the resting mouth temperature by zero point 0.5 to 1 degree in infancy to puberty. In plasma, inorganic phosphate shows a steady fall from the high levels of childhood to reach the adult figures by the age of 15 in girls and 17 in boys. The alkaline phosphate rises significantly in parallel with the growth velocity between the ages of 8 to 12 in girls and 10 to 14 in boys. And at the time of adolescence birth, the erythrocyte count and the blood value of boys now starts to diverge away from that of girls. Um, Another promising index of maturity is the ratio of creatine to creatinine in the urine. This ratio is thought to fall progressively after 14.5 years, and girls maturing early will have a lower ratio than those of the same chronological age but maturing late. Now, next is the chronological age. It is defined as the age measured by years lived since birth. This enables us to determine and predict the rate and magnitude of facial growth and help decide the time, duration, and method of treatment. It may also help to categorize the individual as early or late maturer. However, it is considered as a poor indicator of maturity as it provides little validity for identifying the stages of development progression through the adolescent to childhood. Another is the sexual and the pubertal age. Puberty and adolescent growth spurt occurs in second decade of life. It occurs 2 years earlier in girls than in boys. However, it extends over a period of 5 years in boys and 3.5 years in girls. There is a timetable of sexual maturation, and is classified as and it gives certain characteristics of sexual maturation for both the girls and the boys during the onset of the pubertal or the pubertal age. Features like testicular enlargement, seminiferous tubule canalization, primary spermatocyte appearance, and fine downy straight pubic hair appears in boys. For girls, there is ovarian enlargement, breast develop to the bud stage, and fine downy straight pubic hair. And 1 year later, there is secondary spermatocytes and penile enlargement present in boys, whereas for girls, there is pigmentation of the area lip pubic hair and the hair is now coarser and curling. A year or more later, there is relative enlargement of larynx, beginning with the first ejaculation in case of boys, and in case of girls, there is relative increase of pelvic diameter, beginning with menarche, and the first cycle may not produce ova. A further year or more later, in boys, mature spermatozoa are present. Axillary hair, sweat, and sebaceous glands are very active. Likewise, in girls, full reproductivity is obtained. All axillary hairs are present, and the sweat and the sebaceous glands are very active. Along with this timetable, Hag and Tarangar has made the following concerns in the relationship in time between the various pubertal events. In girls, if the menarche has occurred, then the peak height velocity has been attained and the growth rate is decelerating. If the menarche has not occurred, then the growth rate may be decelerating but has not certainly yet reached the level of the end of the pubertal growth spurt. Similarly, in boys, if a boy has the prepubertal voice, it is most probably that the peak height velocity has not been reached. If the voice changes has begun, the boy is in pubertal spurt, and if the boy has a male voice, the growth rate has begun to decelerate. And no boy will reach the end of the pubertal spurt without having a male voice. Now we have the dental age. Spire in 1918 was the first to associate tooth eruption to the growth stature, and the eruption timetable was made, from which a chronological age can be correlated to the eruption status of a patient. Um, this is the eruption timetable for primary teeth, where we can see the status of eruption in a patient and then compare with this table. Likewise, we also have eruption timetable for the permanent dentition. Now let's move on to the age determination using a growth chart. Growth chart involves the height, weight, and the chronological age of the child. It can be used to follow the child over a time to evaluate whether there is unexpected change in growth pattern. The importance is to determine whether the growth is normal or abnormal and the child is a early or late development phase. It can also determine the peak height velocity. This is an example of how a growth chart looks. Here we have the age, then the height, then the weight and height. A person's age can be determined by comparing their height and weight in this chart. This is a chart for girls of 2 to 20 years of age. Similar, we also have growth chart for boys. This is the growth chart for boys. Finally, we have the skeletal, anatomical, and the radiological age. It is considered to be the most reliable age for assessment of growth for orthodontic purposes. Reasons normally used for age assessment are the head and neck, which is the skull, cervical vertebra, the upper limb, shoulder joint, scapula, elbow, hand and wrist and fingers, lower limb, the femur, hip joint, knee, ankle, foot, tarsus, metatarsals, and phalanges. Now let's start with skeletal maturity. A number of methods are available to assess the skeletal maturity of an individual. This includes the use of hand and wrist radiograph, evaluation of the skeletal maturation using the cervical vertebra, assessment of the maturity by clinical and radiographic examination of different stages of tooth development. Now, first is the hand and wrist radiograph. The hand and wrist region is made up of numerous small bones, and these bones show a predictable and scheduled pattern of appearance, ossification, and union from birth to maturity. Now, let's look into the anatomy of hand and wrist. This region is made up of four groups of bones: the distal end of the long bones of the forearm, which consist of the distal end of the radius and the ulna. Then we have the carpals, which consist of eight small, irregularly placed shaped bones arranged in two rows, the proximal and the distal row. Uh, the proximal row consists of the bones scaphoid, lunate, pisiform, and tricrustal, whereas the distal row consists of trapezium, trapezoid, capitate, and hamate. Then we have the metacarpals, which are the five miniature long bones, and they are now we also have the phalanges, which are small bones, and there are three phalanges in each finger except the thumb. Now moving on to different methods of hand and wrist radiograph. The first is the Atlas method by Grulich and Pyle. Next is the Bjork, Brave and Brown method, the Fishman's skeleton maturity indicator, Hag and Tarangay method, and finally the Singer's method of assessment. Moving on with the Atlas method of Grulich and Pyle. In 1937, an atlas of skeletal maturation of the hand was published by Todd based on the data collected in a study, and Grulich and Pyle based the atlas partly on the atlas by Todd. And this atlas consists either skeletal age pictures of the hand and wrist for different chronological age and for each sex. Each photograph is a representative of a particular skeletal age. Next method is the Bijor, Grave, and Brown method. They have divided skeletal development into 9 stages, and appropriate chronological age for each of the stage was given by Scoff in 1978. In first stage, as we can see, the epiphysis and diaphysis of the proximal phalanx of the index finger are equal, and the male uh, in this age is 10.6 years, and the female is 8.1 years. Likewise, in stage 2, the epiphysis and diaphysis of the middle phalanx of the middle finger are equal. Now, in stage 3, various features like the hamular process, process of the hamate exhibit ossification of the pisiform, and the epiphysis and diaphysis of the radius are equal in stage 3. Likewise, in stage 4, initial mineralization of the ulnar and sesamoid of the thumb and increased ossification of the hamular process of the hamate bone is seen. In stage 5, capping of diaphysis by the epiphysis is seen in the middle phalanx of the third finger, in the proximal phalanx of the thumb, and in radius. In stage 6, there is union between the epiphysis and diaphysis of the distal phalanx of the middle finger. In stage 7, there is the union of the epiphysis and diaphysis of the proximal phalanx of the little finger. In stage 8, there is fusion between the epiphysis and diaphysis of the medial phalanx of the middle finger. And finally, in stage 9, there is fusion of the epiphysis and diaphysis of the radius. Next, we have the Fishman skeletal maturity indicator. It is proposed by Leonard S. Fishman in 1982. It makes use of the anatomical sites located in the thumb, third finger, fifth finger, and the radius, and 4 stages of bone maturation adductor sesamoid of the thumb, capping of the epiphysis, and fusion of the epiphysis. Uh, this is a This is a finger showing a Fishman skeletal maturity indicator. It is from stage 1 to stage 11. In stage 1, the third finger proximal phalanx shows equal width of epiphysis and diaphysis. In stage 2, the width of epiphysis is equal to that of diaphysis in the middle phalanx of the third finger. In stage 3, the width of the epiphysis is equal to that of the diaphysis in the middle phalanx of the fifth finger, whereas in stage 4, there is the appearance of the adductor sesamoid of the thumb. In stage 5, the capping of the epiphysis is seen in the distal phalanx of the third finger. In stage 6, capping of the epiphysis is seen in middle phalanx of the third finger. In stage 7, capping of the epiphysis is seen in the middle phalanx of the fifth finger. And in stage 8, fusion of epiphysis and diaphysis in the distal phalanx of third finger. In stage 9, fusion of epiphysis and diaphysis in the proximal phalanx of third finger. In stage 10, fusion of epiphysis and diaphysis in the middle phalanx of the third finger. And finally, the stage 11, where there is the fusion of the epiphysis and diaphysis in the radius. Now moving on to the Hag and Tarangar method. In this method, there is the assessment of ossification of the ulnar sesamoid of the metacarpopharyngeal joint of the first finger, along with certain specified stages of the 3 epiphyseal bones, the middle and distal phalanges of the third finger, and the distal epiphysis of the radius. This is a figure showing the hand and wrist assessment of Hag and Tarangar, along with uh, along with the middle and distal phalanges and radius. There is the sesamoid bone, uh, which uh, which marks the pubertal growth spurt acceleration. Then we have the radius, which has 3 stages: Ri, which are the Ri, Rij, and Rj. The third finger has the third finger. Distal phalanx of the third finger has only 1 stage, which is the DP3I, where there is the fusion of the epiphysis and metaphysis, and this denotes the deceleration period of the pubertal growth spurt. And uh, in case of the middle phalanx of the third finger, there are 3 different stages. Now moving on to the Singer's methods of assessment. Julian Singer in 1980 proposed this method, and there are 6 stages: the early, prepubertal, pubertal onset, pubertal deceleration, and the growth completion. And corresponding characteristics are present for each stages. Now, um, Now let's move on to the evaluation of the skeletal maturation using the cervical vertebra. This is also known as the cervical vertebra maturity indicators. For this evaluation, lateral cephalometry is used, and only the bodies of the second, third, and fourth cervical vertebra are considered. Two morphologic characteristics are monitored for this method. Those are the presence or absence of a notch or indentation on the inferior border of each of the three vertebral bodies, the shape of the third and the fourth cervical bodies. Now let's move on to the stages. Stage 1 is the initiation stage, which corresponds to the beginning of the adolescent growth with 80 to 100% of adolescent growth expected. In this stage, the inferior borders of all C2, C3, and C4 are flat, and the vertebrae are wedge-shaped, and the superior borders tapers from the posterior to the anterior. Stage 2 is the stage of acceleration, where the growth acceleration begins at this stage with 65 to 85% of the adolescent growth expected. And in this stage, the concavity starts developing in the inferior border of C2 and C3. However, the inferior border of C4 remains flat, and the bodies of C3 and C4 are nearly rectangular in shape. Stage 3 is the transition stage. It corresponds to the acceleration of the growth towards peak height velocity with 25% to 65% of the adolescent growth, and distinct concavities are seen in C2 and C3. C4 also now starts developing concavities on the lower border. The bodies of C3 and C4 are rectangular in shape. Stage 4 is the deceleration stage. It corresponds to deceleration of the adolescent growth spurt with 10 to 25% of the adolescent growth. Distinct concavities are seen in the inferior border of C2, C3, and C4. The vertebral bodies of C3 and C4 are becoming more square in shape now. Stage 5, the maturation stage. Final maturation of the vertebra takes place in this stage with 5 to 10% of adolescent growth expected. More accentuated concavities are seen in the inferior border of C2, C3, and C4, and the bodies of C3 and C4 are nearly square in shape. Stage 6 is the completion stage, which corresponds to the completion of growth, and little or no adolescent growth will be expected in this stage, and deep concavities are seen in C2, C3, and C4. The bodies of C3 and C4 are square or were greater in vertical dimension than in horizontal dimension. This is a simple figure showcasing how a cervical vertebra changes from the initiation phase to the deceleration to the completion phase. This is a figure from where we can see how a cervical vertebra staging can help us to know in the mandibular help us know about the mandibular growth. The peak of the mandibular growth occurs between the cervical stage 3 and cervical stage 4, and keeping this in mind, we can formulate various treatment plans. Now let's look into the application of cervical vertebra stagings in dentofacial orthopedics. Class 2 treatment is most effective when it includes the peak in mandibular growth, that is in stage 3, and class 3 treatment with maxillary expansion and protraction is effective when performed before the peak, that is either in stage 1 or stage 2, and deficiency in Ramosai should be treated at the peak in mandibular growth, that is stage 3. Now let's move into the tooth mineralization as an indicator of skeletal maturity. The calcification patterns and the change of mineralization of the teeth is believed to have a close relationship with the skeletal maturation of an individual. The dental development can be assessed by either the phase of tooth eruption or the stage of tooth calcification, and it can be done by examination of the panoramic radiograph. Advantages of this method over the hand wrist radiograph is dentists are more familiar with the stages of dental development than with skeletal maturity indicators present in hand and wrist radiograph, and no additional exposure is required in this case. Seymour Chortno has described the method of determining the skeletal maturity based on the mineralization of the lower canine. Likewise, Demirjian, Goldstein, and Tanner have also described the similar method. Now let's look in detail in the Demirjian index. There, There are various stages. Now let's move talking about stage one. In this stage, there is calcification of the single occlusal points without the fusion of different calcifications. In stage B, there is fusion of different mineralization points. The contour of the occlusal surface is now recognizable. Stage C, enamel formation has completed at the occlusal surface and the dentin formation has commenced. The pulp chamber is curved and no pulp points are visible in this stage. In stage D, crown formation has been completed at the level of cement enamel junction. Root formation has commenced. The pulp points are beginning to differentiate, but the walls of the pulp chamber remain curved. In stage E, the root length remains shorter than the crown height. The walls of the pulp chamber are straight, and the pulp horns have become more differentiated than in the previous stage. In molars, the radicular bifurcation has commenced to calcify. In stage F, the walls of the pulp chamber have now formed an isosceles triangle. The root length is equal to or greater than the crown height. In molars, the bifurcation has developed sufficiently to give the root a distinct form. In stage G, the walls of the root canal are now parallel, but the apical end is partially opened. In molars, only the distal root is rated. In stage S, the apex is completely closed. The periodontal membrane surrounding the tooth and the apex is formed in width throughout. Now, concluding my presentation, precise evaluation of the maturational stage should be an integral part of both diagnosis and treatment. Different authors have reported different methods in an attempt to determine the best indicator of maturity. Every method has its own advantages and disadvantages over the other method. However, still researches are being done to explore the best method to assess the maturity of an individual. These are my references. Thank you.